to talk about what more can we do within surgery, and why is surgery such a focus, and why we've actually not been terribly good at tackling antimicrobial stewardship within surgery. So I just want to mention that we are part of a ESRC, Economic and Social Research Council, international study looking at antimicrobial use across surgical pathways. And this is a program of work that involves India and South Africa. And it's a real pleasure to work on this with international colleagues. And the reason that we really need to focus on surgery is that, of course, surgical specialties are responsible for a massive amount of antimicrobial use. And in terms of patient outcomes, AMR is a major driver of poor surgical outcomes. This data from the USA is also extraordinary about looking at modeling the differences in resistance in terms of surgical prophylaxis and what it would mean in terms of SSIs. Was a real kind of wake-up call to the US paper from Lancet Infectious Diseases in 2015. And of course, the impact of surgical site infection is beyond AMR. It's the contribution to the prolonged hospital stay and potentially further surgical interventions. But thinking outside the USA and the rest of the world, this is quite horrific data. About 11% of patients undergoing surgery getting a hospital-acquired infection. And this is this large commission study which also identified the particular burden for women in C-sections, 20%, absolutely dreadful. And then we also need to remember that if you're in infection prevention, it's all the talk is about SSI. Surgical infections are not just SSI. They're the postoperative pneumonias, they're the UTIs, the bacteremias. And the other thing that I want to flag, and this is, of course, something that Luke Moore has quite an interest in, is, of course, burns patients. And the management of burns, particularly in low and middle income countries, is within the domain of surgeons, and it's counted within surgery. And this is such an enormous problem, resistant infections in burns patients. And as I said, the data, particularly in some of these larger studies from Africa, are really, really just shocking. So postoperative complications and postoperative mortality that gets reported, we need to remember that so much of that is infection and much of it is due to AMR. And this is a kind of shocking reminder of that came out in 2019. The data is not granular enough to break it down into the types of infection, but you can see the burden of postoperative deaths there in the pink. And in terms of what more can we do about this, and I'm wanting to take this outside the realm of diagnostics and resistance patterns, and what can we do as teams and as humans and as people working in our hospital trying to provide best care. So this was a study looking at African hospitals. I think this is a rather, so the study was led by Benedetta Allegranzi, who many of you know from WHO. But I thought this editorial is particularly elegant, which is about cold steel might cure, but it takes a village to prevent surgical infections. So, and with that, I want to talk about how we perhaps could work a little bit more productively in preventing these infections and using antimicrobials a little bit more wisely. So, I mentioned at the beginning about how important it is that we think about behavior and how we work in teams. Our colleague Esmita Chirani has led much of the work in this field and pioneered this critical aspect of antimicrobial stewardship. And many of us working with our wonderful and gorgeous surgical colleagues will realize that actually working together and the qualitative and the behavioral component and how people work in hierarchies is very, very important to understand to get things done. So really important that this is understood, and we use it to actually develop effective antimicrobial stewardship together. Behavioral change is critical in that we understand it, and that we actually understand the unspoken rules in terms of how we manage patients together. Really important that we understand that. And to get these kind of views of clinical autonomy and hierarchies and the role of peer specialty and peer advice, how can we use that to work together and actually leverage what we want in terms of antimicrobial stewardship and improving their patient outcomes? So we're not doing terribly well in terms of working with our clinical leaders, and I think we could do much more there. And all the social science and behavioral evidence shows how critical this is if you're wanting to make any change. Work with the leaders. I'm delighted that in the ASPIRE study that I described, we have got some tremendous leaders. I'm just highlighting a couple here from that are incredibly senior leaders in the fields of hepatobiliary surgery in India, in terms of anesthetics in the UK and internationally from Ramani Minasinghe and Jules Ndoli, who's the major international lead for patient safety and also oversees, is an anaesthetist and oversees ITU and anesthetic care in Rwanda, where there are very, very few anaesthetists and most work is done by technicians. Not there are nursing leads and pharmacist leads, but I just want to emphasize how critical it is that we work with lead surgeons and with lead anaesthetists and recognize the importance of perioperative medicine. We need to treat surgeons differently. They are not the same, not just on a, not just in an individual profiling way, but their work patterns are not the same and how they manage patients are not the same. We need to recognize this and work with them. Really, really critical. And it's not just about the teams and the dynamics, but it's also about how decisions are made and how the day-to-day working of the team. Critical that we understand that. And there's beautiful ethnographic work led by Asmita that has fed into this thinking. We need to bend around this and accommodate all of this. There was a beautiful editorial in Clinical Infectious Diseases about the need to recognize this if we are going to make changes and help tailor our interventions that absolutely recognize how surgeons work, but also the surgical pathway. And I'm going back to what I was saying before about working along pathways. And for surgeons, the antimicrobial management, of course, it's peripheral to their central role. And also, we need to recognize the complete lack of continuity and the disjointed information because of the way that people work. And how can we help with this? And could there be a role for developing perioperative medical care within surgery, working with anaesthetists and lead surgeons? And could we develop these types of clinical roles? So there's some quite exciting progress there. There's major scope for perioperative antimicrobial stewardship. This is just one map mapping out decision making. Within that little kind of dotted box are the things that should be discussed at every ward round. But this is a causal diagram that's helping influence and change how we work with antimicrobial stewardship within surgery. And important, as I said, that we look at the whole healthcare economy. It's not just what happens when you're in ICU or when you're in theatre. It's from the very beginning across the operating theatres, all the little shoes outside, and to how we use our community pharmacies. We need to understand it all. Thank you very much.